Hello and welcome back to BunMed. We're continuing with our impaired hemostasis disorders, looking this time at disorders of secondary hemostasis in the form of that of hemophilia A and B, and as well as that finishing on disseminated intravascular coagulation. So in this series so far, we've covered disorders of primary hemostasis, and in this video, we will not only be looking at secondary hemostatic disorders, but also finishing on some SBAs as well, just to really help us solidify our understanding. So with that said, let's get into hemophilia. What does hemophilia refer to? Well, we know that hemo refers to blood, and philia refers to a likeness towards or a tendency towards. So in hemophilia, there's a tendency towards bleeding, and patients tend to bleed quite often. And this is often a genetic condition in most cases. It's a congenital condition, meaning it's present from birth. However, in up to 30% of cases, there may be no genetic link whatsoever. And this type of genetic condition is one that occurs in the X chromosome, and thus it's X-linked. So let's start with what happens. Here we can see we have the X and Y chromosome. Now, if we just take a look at it, we can automatically see that the X chromosome is significantly longer than the Y chromosome. Now, this is actually very interesting because it allows for a dynamic that we're about to see being set up. And that dynamic is that the X chromosome is actually able to bend around itself, unlike the Y chromosome, putting these two very special regions next to each other. Now, it's in this region that we find the factor VIII and factor IX genes, the two factors that are actually deficient in hemophilia A and B. And because the X chromosome has bent around itself, genes can start to cross over and switch over, and therefore we get disruption to, or messing up of our factor VIII and factor IX gene, meaning that we end up producing reduced amounts or not at all of factor VIII and factor IX. So hemophilia, therefore, is a deficiency of either factor VIII in hemophilia A or factor IX in hemophilia B. And usually factor VIII deficiency is significantly more common. And also this occurs, as we saw, was due to what we call a flip tip inversion, where the X chromosome crosses around itself, leading to this X-linked recessive condition. So what's the consequence of not having enough factor VIII and factor IX? Well, we know that factor VIII and factor IX take place in the clotting cascade to help stabilize our platelet plug and help form fibrin, right? And we know that looking at the clotting cascade, that they take part specifically in the intrinsic pathway, where in the very last step of the pathway, factor VIII and factor IX together help to go on to activate factor X into factor Xa. If, therefore, we have a deficiency of either factor VIII or factor IX, we can see that we're halting the intrinsic pathway. And therefore, we're not able to help produce fibrin, so we can't help produce our fibrin sheath or help stabilize our clot. So what kind of symptoms is this going to lead to? Well, the first one's not really a symptom, it's more of the demographic. And because it's an X-linked condition, this tends to often be seen, the congenital form that is, in males. The non-congenital form or acquired forms of hemophilia can be seen in both males and females, and is often due to things like exposure to radiation. Okay, so that's the first demographic. The first symptom that we might see, especially in infants, is that they tend to bleed a lot more or take a lot longer to stop bleeding during their heel prick test, a test that helps us to rule out some very, very important conditions from birth, one of them being things like sickle cell anemia. Continuing on with this, we might get things like, as the child is growing up, if they have minimal trauma like falling over, they may bleed into their muscles. As well as that, if they fall on their joints, they may bleed into their joints. And this is a really big problem in poorly controlled hemophilia, is that hemophiliacs tend to get really bad joint disorders and really, really bad arthritis as they get older because of the recurrent bleeds into their joints. And lastly, they may have extensive and large bruises. Now you can see how this is different to that of our primary hemostasis, where we saw a petechial and a purpuric rash, which are these needle print points of bleeding, rather than these large areas of bleeding and bruising. And this is mainly because we can't stabilize our platelet plug. So what kind of investigations are we going to want to do? Okay, well, in any bleeding disorder, we have to always ask the question, is this an issue with primary or secondary hemostasis? So let's rule out the issue with primary hemostasis by doing some FPCs. And in our full blood count, because we have no issues with the platelets, it's going to be completely normal. The next thing we want to do is check if our secondary hemostasis is working correctly. And we do this by doing some clotting studies. And we know in this case, because we are turning off the intrinsic pathway, we're going to have a prolonged APTT. The next thing then we can do is actually have a look at what factors are deficient by doing a factor 8 and factor 9 assay. And usually, in most cases, since factor 8 is more common, we're going to see reduced amounts of factor 8. If we have hemophilia B, however, we might see normal levels of factor 8, but a reduced level of factor 9. Another thing that we can do is if we have normal levels of both is that we can do a functionality assay. So for instance, if we had normal levels of factor 8, but our factor 8 was dysfunctional, we'd still get the same symptoms. The next thing we want to do is make sure that there's no issue with the transport of the factors. And we know that factor 8 is transported by Von-Willebrand's factor. So therefore, we can do a Von-Willebrand factor assay just to ensure that our Von-Willebrand is also behaving the way it's supposed to. And lastly, we should do some LFTs or liver function tests. And the reason for this is that our factor 8 and factor 9, like quite a lot of our proteins, is actually produced in our liver. So therefore, we can do some LFTs just to make sure that our liver is not dysfunctioning. So what kind of management options are there for hemophilia A and B? Well, first of all, if we just break it down to the very simple steps, what is it? It's a deficiency of factor 8 or factor 9. So therefore, the best thing to do would be to replace those factors. Within hemophilia A, things like recombinant factor 8 or something that you call octocog alpha. In the acute scenario where recombinant factor 8 may not be available, we can use other means of bypassing the intrinsic pathway. So what do I mean by this? Well, look, we have blocked the intrinsic pathway, but we can still upscale the action of the extrinsic pathway to help us produce fibrin, because look, factor 7 is still helping us to go to produce fibrin. So one of the things that we can do is give activated factor 7A concentrate, just to help us build more fibrin. Should this not be available, we can give something like an antifibrinolytic, meaning whatever clot that we do have is not broken down as easily by giving tranexamic acid, and we can help to force more factor 8 from our endothelial cells directly into circulation with the giving of desmopressin. Should this still not work, another thing that we can do is give something like cryoprecipitate. Now, cryoprecipitate is a blood product that contains quite a lot of things, but one of the things that it actually contains is factor 8 and Von-Willebrand factor. So we can give cryoprecipitate just to replace some of the factor 8 levels. And if that doesn't work, and this is still done in much more poorer countries where things like cryoprecipitate or factor 8A concentrate might not be available, is give something like fresh frozen plasma, because this contains all of the clotting factors in our plasma. And we will talk about all of the clotting factors and all of these blood products in a separate video. So that's basically hemophilia A and B. Let's focus on DIC. Okay, so what's DIC? Well, DIC refers to disseminated intravascular coagulation. And from these, we can understand that we have formation of lots and lots of clots inside of our blood vessels all over our body by the use of the word disseminated. Okay, so how does this process occur and what actually goes wrong? Well, this process all gets started off with something, and we don't exactly understand what that exact thing is. And it could be many things, but some of the more common things that we are aware that it can be caused by is things like snake venom, sepsis, pregnancy, malignancy, specifically if you have a type of acute myeloid leukemia where you have a 15-17 translocation, or pre-myelocytic leukemia, you're at a really high risk of this, and as well as that, trauma. Okay, and a good acronym to remember this is snake spit poisons many times. So snake for snake venom, spit for sepsis, poison for pregnancy, many for malignancy, and times for trauma. And we know that this process actually goes on to activate our clotting cascade inappropriately by activating factor 7A. So factor 7 and factor 3A is activated in an inappropriate manner, and therefore this kickstarts the clotting cascade. So what actually is it? Well, we have uncontrolled formation of clots all over our body due to the inappropriate activation of the clotting cascade. And every time we form a clot, we actually use up those clotting factors. So therefore, we end up using up not only the clotting factors in our body, but also the platelets. So as you can imagine, as this process gets kick-started, we start to form these clots. Now, these clots, like we saw in many other times before, are actually quite sharp. So as blood cells try to pass through them, they get sheared in half, leading to hemolysis. So this is another type of microangiopathic hemolytic anemia. Now, these clots can then get deposited all over the body, leading to symptoms of things like thromboses, both in the venous and arterial system. But the more important thing is that we actually used up the clotting factors. So therefore, we're at a significantly higher risk of bleeding. In fact, any tiny trauma can cause us to bleed. So therefore, this condition is a true medical emergency. Okay, so what sort of symptoms are we going to see? Well, we're going to see symptoms of the underlying condition. So for instance, if it's like sepsis, you're going to see symptoms of sepsis like a high fever, tachycardia, potentially things like shortness of breath, drowsiness. But in terms of the condition itself, you're going to see things like oozing from venipuncture sites because we can't clot. And this may occur completely spontaneously. So for instance, where you put in a cannula or a venipuncture, the site just randomly starts bleeding. You might also notice spontaneous bleeding from other sides, such as the mouth or the ears. Other things include, from a more clotting side of things, that if these little clots get shot off, they can actually get lodged in smaller vessels, like those in your hands and feet, leading to digital infarcts. A digital infarct refers to the death of a finger or toe. And it's pale because it can block off one of those arterioles. So this is a very serious condition. So what sort of investigations are we going to want to do? Well, the investigations that we're going to want to do is to start off with some basic bloods. And the first thing we do is a full blood count. Now, because this is a microangiopathic hemolytic anemia, we're going to see a thrombocytopenia and a normocytic anemia. The next thing that we're going to want to do is a blood film. The reason we do a blood film is to detect these things known as schistocytes. And schistocytes is, again, like I've said before, where a red cell is cleaved in half, leaving these helmet-shaped remnants of the red blood cell. The next thing we want to do is some U's&E's. Now, U's&E's are really, really important, as any sort of systemic disease like this tends to affect the kidneys the earliest and can lead to acute kidney injury. So therefore, we may see things like a raised urea and raised creatinine. On the side, you should also do something like a urine dipstick, which may show the presence of blood or protein in your urine. The next thing we want to do is clotting studies. Now, this is where it starts to get interesting, okay? Because you can't actually localize this lesion. Okay, what has actually happened? Well, we have started to form uncontrolled clots using the clotting cascade. So all of our clotting factors have been used up. But in the using up of those clotting factors, we've used up our platelets as well. So we have a deficiency now in both primary and secondary hemostasis. So you're going to see a raised bleeding time as well as a raised PT and raised APTT. Now our body is very interesting in the fact that it will not deal with so many clots in our body, and it will actually try to break down these clots. And in the process of trying to break down these clots, it produces a type of protein that we can detect by doing some D-dimers. And in DIC, because we're forming so many of these clots, our D-dimers is significantly raised. Another thing that we can do is do a serum fibrinogen. Now remember, we are again forming lots of clots all over our body. So therefore, our serum fibrinogen tends to be low because we are using it all up to form all these clots, and therefore this is what leaves us at such a high risk of bleeding. So what's our management? Well, in any acute condition like this, the first thing we do is an ABCDE, and we also try to treat the underlying cause. So if this is sepsis, start them on the sepsis 6. In order to actually deal with the underlying clotting disorder in terms of a bleeding disorder, we actually try to replace all of our clotting factors by giving them fresh frozen plasma. And this essentially contains every single one of our clotting factors, and therefore it's very effective in the treatment of disseminated intravascular coagulation because it replaces all of the factors in one go. The next thing we can do is give cryoprecipitate if fibrinogen is low, because cryoprecipitate is a concentrate of things such as fibrinogen, factor 8, and Von-Willebrand's factor mainly. So you can see it does replace quite a lot of the factors that we're deficient in. And we also want to give supportive care. So what I mean by this is if they need fluids, give them fluids. If they need oxygen, give them oxygen. And this is basically based on the patient needs. And last thing, of course, as I said before, the biggest thing to stop it going on is to treat the underlying cause. Okay, let's jump straight into our SBAs. Now, if you haven't watched the previous videos on things like primary hemostasis, I would really recommend just checking those out, because all of the questions are actually questions from all 3 videos and not just this one. So with that said, let's get into our first question. We have a 27-year-old female who presented to the GP due to a strange rash appearing over the back of her legs following a bout of an upper respiratory tract infection. She expressed that she's also noticed a few nosebleeds over the last couple of weeks, but didn't think much of it. On examination, you confirmed the purpuric rash over the back of her legs and otherwise is normal. On an FBC, the following are seen. Pause the video now and have a go at answering this question. Okay, so the answer here, of course, we're getting towards is ITP. Now, if you're wondering why ITP it is, let's actually break down the history, and let's see what in the history points us towards a diagnosis of ITP. So here you can see I've highlighted in red the things that points towards the diagnosis of ITP. So let's start with a 27-year-old female. ITP is much more common in those women of childbearing age. So that's a good demographic that kind of helps us confirm the diagnosis. Now, this strange rash appearing over the back of her legs, we know it's a purpuric rash from later on. So therefore, we can already tell there's some degree of issue with clotting going on. And this is because we're having bleeding underneath our skin, so therefore we're getting a purpuric rash. Now, the most important thing here is that it's coming on following a bout of an upper respiratory tract illness. Remember, ITP, especially the acute form, typically follows a bout of an upper respiratory tract illness. And therefore, this is pointing more and more towards a diagnosis of an issue of ITP or an issue with platelets. Now, we can see even further evidence being added that we have some kind of a bleeding problem when we see that she's also been getting few nosebleeds. So from this point, we can work out that she's having an issue with a bleeding disorder. So we have to do some investigations to really localize exactly where in the clotting process it's going wrong. And the first thing we do is a full blood count. And here you can see an isolated thrombocytopenia. So you can see the hemoglobin is completely normal, MCV is completely normal, white cells are completely normal. So in the presence of an isolated thrombocytopenia, when this occurs after a bout of an upper respiratory tract infection, this is most likely to be an ITP. In Von-Willebrand's disease, the platelets are usually normal, so the platelets should not be low. In TTP presents with a pentad of 5 very specific symptoms that we'll get into later on. So therefore, here you can't really see the 5 pentad symptoms, so it's unlikely to be that. It's unlikely to be acute lymphoblastic leukemia, not only based on the age group, as acute lymphoblastic leukemia tends to affect mainly children, but also the fact that you can see hemoglobin and white cells are completely normal. And usually in leukemia, you'll see a very high white cell count. And it's unlikely to be hemophilia, as our platelets are normal, and in hemophilia, our platelets are low, and in hemophilia, the platelets should be normal. Okay, let's move on to question 2. So now we have a 3-year-old boy who's brought into A&E following a fall. He was brought in by his mum due to him being unable to walk after the fall, and he appeared to be in severe pain. On examination, his knee appears to be swollen and tense. His full blood count, however, is normal, and his clotting studies showed a raised APTT. Which of the following is the likely mechanism behind his underlying diagnosis? So please pause the video here and have a go at answering this question. Okay, so the answer here is actually X-linked and X-linked recessive. So what's this diagnosis, the underlying diagnosis it's getting towards? Well, let's again just highlight the things and let's see what we can come up with. So we know it's a 3-year-old boy, okay? And it's likely that this diagnosis presents early in life if he's only 3 years old. Now we can see that after a fall, he's unable to walk, and why? It's because his knee is tense and swollen. If a joint is tense and swollen, it suggests there's extra things inside that joint, such as blood. So this boy is likely bled inside of his joint. Now, what have we learned from our previous video that presents with bleeding inside of the joints? Hemophilia, right? Okay, so we're already thinking that this is potentially a diagnosis of hemophilia, especially the fact when we consider that this is a boy, and remember that X-linked recessive conditions often tend to show up in boys. So let's continue and let's look at his investigations. His FBC is completely normal. We expect this because hemophilia is a condition of secondary hemostasis, not primary hemostasis. So the platelets should be normal, everything else should be normal. However, his clotting study showed a raised APTT. Yes, because in haemophilia, when we're either missing factor VIII or factor IX, we're actually shutting down the intrinsic pathway, and thus we raise the APTT. So all of this points towards a diagnosis of haemophilia. And remember, in haemophilia occurs the congenital version due to a flip tip inversion on the X chromosome, so this is X-linked. Let's move on to question 3. So now we have a 4-year-old girl who was brought into the GP by her mother for lacking energy. She states that her daughter has been experiencing 3 episodes of bloody diarrhea and high fever in the last week following a visit to her friend's birthday party. On examination, you notice slight scleral icterus, so icterus means yellowing, as well as conjunctival pallor. Her FBC is shown below. Please pause the video and have a go at the question. Okay, so the most likely thing that we're going to see on a blood film is schistocytes. Now, why are we likely to see schistocytes, and what is the underlying diagnosis? Well, the underlying diagnosis here is hemolytic uremic syndrome, the condition which occurs if you get infected with the very certain and very specific species of E. coli known as the O157H7 species. Now, how can we get to this diagnosis? Well, let's have a look. So we know this is a 4-year-old, so we can already tell, again, in a child, an HUS often tends to occur in children who have had contaminated foods. They're lacking energy. Why might they be lacking energy? Well, remember, in HUS, it's a microangiopathic hemolytic anemia, so our red cells are being broken down. So therefore, they're going to be anemic and lacking energy. She states that her daughter has had 3 episodes of bloody diarrhea. Now, the toxin produced by the E. coli O157H7 actually causes diarrhea, more likely a bloody diarrhea. High fever because she has had the toxin inside of her system. And following the friend's birthday party, now that is a major clue, because when you have a birthday party, you have people who are eating things, especially children may not be washing their hands, or there may be contamination of the food. So therefore, that's a key clue as to how this came on about. On examination, you notice scleral icterus. Well, the yellowing of the sclera is often a case due to high levels of bilirubin in the blood. Well, jaundice. Why would we have jaundice? Because our red cells are being broken down and we're releasing lots and lots of bilirubin. And conjunctival pallor is again showing that this person has anemia. And this is reflected again in their full blood count, where we see a hemoglobin of 102, which is quite low, and a platelets of low as well. And these are the hallmarks of a microangiopathic hemolytic anemia. Now, remember, we said the clots formed are very sharp, so when the cells move through it, they get sheared in half. Okay, so that's why we see schistocytes. Now, it's unlikely to be a Heinz bodies, as this is often seen in G6PD deficiency. Video coming up on that quite soon. Spherocytes is again another type of hemolytic anemia that's congenital, but it's not HUS. Elliptocytosis is again another genetic condition that's another hemolytic anemia, but it wouldn't have it wouldn't present in HUS. And poikilocytes is something that we often see in something like iron deficiency anemia. So our next case is a 65-year-old lady on the respiratory ward who was found to be tired, very lethargic, and drowsy. She was admitted yesterday with a bout of pneumonia. On arrival, you see the patient is bleeding from her cannulation site. She has reportedly also started bleeding spontaneously from her ears just before you got here. On examination, she has a temperature of 38.2 degrees, a pulse of 118 beats per minute, and a blood pressure of 89/60. After stabilizing her, you order some clotting studies. Given the underlying diagnosis, what do you think is likely to be seen in the clotting study? So please pause the video here and have a go at answering this question. Okay, so the answer here that's getting towards is a raised bleeding time, a raised PT, and a raised APTT. So what is the underlying diagnosis, and why is it giving us this picture? Okay, so let's have a look. We have a 65-year-old lady. Okay, so it's more the fact that she's feeling tired and drowsy and lethargic. That's what we're interested in. Okay, she was admitted yesterday with a bout of pneumonia. We already therefore know that she has a chest infection going on. On arrival, you see the patient is bleeding from her cannulation site. Now, this isn't that common. Especially after you've done the cannulation, it shouldn't just randomly start bleeding. What's even more worrying is that she spontaneously started bleeding from her ears. So you know that something is really wrong for her to be bleeding all over the body without a given cause. What's even more worrying in this case is when we start to look at those examinations. Her temperature is spiking at 38.2, which is fairly high. Pulse of 118, again, she's tachycardic, she's got a high fever, and a blood pressure of 89/60. Well, her systolic is actually under 90, so we know that this patient is actually quite ill. And this patient with a high temperature and a tachycardia and a low blood pressure is looking more and more like septic. So what goes together when we have someone who's septic, and we know the cause of her septicemia might be the pneumonia? What goes together with sepsis and spontaneous bleeding? What we said is DIC, right? So the biggest thing here is that you stabilize her and you start the sepsis 6, then you order some investigations for the DIC, or the disseminated intravascular coagulation. Now remember we said that in DIC, we have used up all of our clotting factors and a lot of our platelets forming random clots all over our body. So therefore it's going to raise our bleeding time, raise our PT because it's affecting the extrinsic pathway as well, and raise our APTT as well because it's affecting our intrinsic pathway. Okay, now we have a 25-year-old pregnant lady who's admitted due to lack of consciousness. When she comes around, she's found to be very drowsy. She appears to have a purpuric rash over the back of her legs. On examination, she has a fever of 38 degrees. She's found to have scleral icterus and conjunctival pallor. Bedside urine dipstick shows a presence of protein in her urine, and her usine shows a raised creatinine and urea. Her full blood count is shown below. Please pause the video here and try to work out what's the underlying mechanism of the disease. So here, of course, we're trying to get at the disease of thrombotic thrombocytopenic purpura. And in red, I have highlighted the pentad that I was talking about before of all the things that we're looking for. So let's break it down. She seems drowsy. Why might she be drowsy? Well, remember, one of the components of our 5 pentads is actually neurological dysfunction, and the way that it may present is feeling drowsy. She appears to have a purpuric rash over the back of her legs. Number one thing that tells us is this is likely to be a thrombocytopenia. Okay, so that's already, we filled out 2 of the criteria. On examination, she has a fever of 38 degrees. Fever is another one of those criteria, so therefore, that's 3 of the 5 criteria. Scleral icterus and conjunctival pallor. Scleral icterus, remember we said, is because she's got a lot of bilirubin in her blood, likely due to the fact that she's breaking down more and more red cells. And the conjunctival pallor, again, is showing that she's lacking in red cells, leading to an anemia. Bedside urine dipstick showed the presence of protein in her urine, and the usine shows a raised urea and creatinine. And there is the 5th element of our pentad. So you can see we have had a fever, neurological dysfunction, renal failure, thrombocytopenia, and anemia. And remember we said that TTP occurs due to the lack of or a deficiency in the ADAMTS13 enzyme, which can't cleave Von-Willebrand's factor. On to our very last question then, is a 30-year-old man who presented to the GP having bled excessively during his dental extraction. He says that his mother had a tendency to bleed as well. On examination, he is otherwise normal. A full blood count is carried out, which is again normal. Clotting study shows a raised bleeding time and a raised APTT. What is the most likely underlying diagnosis? So here the most likely underlying diagnosis is von Willebrand disease. So let's just break down his history again and to find out why it's likely von Willebrand. Okay, so we can see the first thing that this is likely a bleeding disorder because he's bleeding excessively at the dentist. But he's not bleeding elsewhere, so we can tell that this isn't a very, very significant bleed. It's just something that happened at the dentist. We find out that his mother had a tendency to bleed as well. Now you're probably wondering, hang on, there's a genetic component. Could it be Haemophilia A? Especially if we see a raised APTT. And he is a male, but the thing is, if his mum is having a tendency to bleed, remember, haemophilia tends to be X-linked recessive, so it would be strange to see his mum being affected by haemophilia. She may be a carrier, but in a carrier, you wouldn't expect to see the bleeding. On examination, a full blood count is absolutely normal. Well, absolutely, in von Willebrand's disease, we're not going to see a thrombocytopenia because, remember, our platelets are fine, we're missing our von Willebrand factor. She has a raised bleeding time because von Willebrand is involved in primary hemostasis, and a raised APTT because it helps to shuttle around factor VIII around the body. So that's the end of the video. Thank you so much for tuning in. I hope the SBAs have been helpful in just helping to solidify some of the stuff that we've learned today. If you have any further questions or comments, please do leave them in the comments below, and I'll try to get back to them as soon as possible. Please do consider subscribing and sharing the video and just helping the channel grow. Thank you.